If I were to spend my time on lectures, this is not one I would spend as much time studying. There's not going to be a lot of test questions just because I think these just not that exciting. There's more important things to cover. But check on learning here. Anybody can remember back to the Framingham study? It was done on the East Coast. Unfortunately, this isn't good, but another word for D, idiopathic. So, obviously, cardiac's concerning. Vasovagal's not. Seizures and orthostatic can be, but we don't know. About 40%. 4 out of 10 times we're not going to know what that is. Unknown. I never talked about micturition syndrome or postprandial hypotension, so those are out. We talk about static, but little kiddo's touching on his neck, so pretty much rest assured that that's B, correct? B. Nope, an ornament's on the tree, so rest assured that's some clavian skills. Pretty simple. Now we're going to get into exciting stuff. These last lectures are all pretty short. We're going to get into diabetic ketoacidosis. I'd say that this is important if you're going to be training at BAMC. You've seen more DKA and its sister, HHS. So hyperosmolar hyperglycemic syndrome, those two run together. Both deal a lot with people that are dehydrated. But with our diabetic ketoacidosis, I'm going to explain to you, we need to figure out what the inciting event is. So, DKA, eyebrow stuff here. Issue, there's your objectives. This is a whopping 26 slides, so we'll just run through it. We'll get through what we can today so that I'm not keeping you so late on today. Sounds like a plan. Everybody likes being here past John. So I want you to pay attention with this is substantial dehydration. DK, these people are at least 4 to 5 liters down. There's an inciting factor there, and then what happens with that is concerning. With that sugar, and if you understand osmosis, I'm not taking you back to freshman semester, but you need to have that idea of pathophysiology, that's what happens. That hyperglycemia causes all these electrolytes to shift from the blood to third spacing, pushing into cells where they're not supposed to be. We need that's the state of the blood. So what we get concerned about is potassium with this. Total body potassium. It doesn't disappear, it just goes to where it's not supposed to be. It's where it's not supposed to be. We do want to avoid intubating these people. Why? Because most of them, when their sugars are getting high, they have Kussmaul breathing, they're breathing fast. Why are they breathing fast? Because they're acidotic. They're trying to blow those hydrogen ions off. And that's what the body does when it goes into an acidosis. They're having tachypnea, they're trying to reduce that. We want to make sure, sometimes these people are non-specific, they're not going to come in and say, oh, I feel hypoglycemic. No, they're going to come in, they don't feel right. They're going to complain of dizziness. They don't know why. So just remember, very non-specific types of findings. I'm not going to come in and be like, oh, your blood sugar's too low. No, we don't know. I don't know that. So infection is the #1 cause. We'll talk about the 7 I's. So I said we need to find the underlying cause of this. Why does that person have that issue? Now, when it's around the holidays, Thanksgiving, Christmas, people will come in and say, yeah, I just like eating good stuff, and I've been having a lot of time with family and eating lots of pies and different things like that. Very rare in adults, but again, that hyperglycemia causes significant cerebral edema in kiddos, which is why we get a little bit more worried about them. Plus, they're poor at explaining what they have going on. But cerebral edema, usually not a big issue with adults, but in kiddos, we get very, very concerned about that. That's a life-threatening thing. Okay, diabetes. What causes this? Sometimes these people come in, that's their first time that they are having this issue versus a known diabetic. Typically, it's type 1 diabetes. That means that they are born with it. Yes, there is late onset. We have about 1 in 3 are type 2 diabetes. They develop it later on in life. Did I think that I needed to know a lot about diabetes when I was a primary care? No, I didn't. But I diagnosed 2 of my medical platoon sergeants in my brigade the first 6 months at Fort Bliss. One with late onset type 1, the other one with type 2. So, one guy took a med board, the type 1, because he didn't want to be compliant with lifestyle changes. The other one I took with me to Afghanistan on deployment. Made sure his hemoglobin A1C was under 7. He wasn't on insulin, and able to deploy, did not require a medical board. Still a good buddy of mine, because he decided that he was going to change things. Yes, go ahead.
Sir, is being on insulin the only major decider for deployment purposes?
If somebody's on insulin, unless they are the only MOS of that particular job, they require refrigeration, that's usually a medical board.
Okay.
They're insulin dependent diabetes. So if they can do lifestyle changes, watch what they eat, stay on just metformin. By the way, hemoglobin A1C is a good indicator of how compliant they're being. If they let their sugars get out of control, that A1C is going to be through the roof. So if people come in with an A1C of 13, I'm like, you just really don't give a shit, do you? Is what it is. That means they're letting their sugars just skyrocket all the time, not paying attention, don't want to take care of themselves, so be aware of that. So, usually insulin deficiency is how it goes, and that's why when we talk about pancreatitis and the pancreas, why it's so important, because it secretes that insulin. So, has a lot to do, this is a big hormone thing, which is why these people see endocrine doctors. I'm not going to ask you any pathophys on all this stuff. Just understand that excess production and underutilization of glucose is what causes all these different type of hormones to get out of control. So it's like a cascade. I mean, it's not just the sugar that's getting out of control. We're having all these other types of things. Having trouble regulating all that. Right there, hyperglycemia causes all these other types of things. Starts affecting the kidneys, causing azotemia. We get this osmotic diuresis, which is why people, what is your symptoms that we get concerned about? So right off the bat, polyuria, polydipsia, the unquenchable thirst. That's why they want to drink all the time. That's their body trying to get rid of that glucose, try and dilute it out, and then they're peeing all the time, so they're drinking all the time. So polyuria, polydipsia, that comes in, and they're having weight changes, that's diabetes all day long. So we get this ketone formation, which is why it's diabetic ketoacidosis, and then we develop that metabolic acidosis. Bad. Too much sugar in the blood, it allows bacteria just to start getting crazy, which is why we worry about infections. Look at all these different causes. I got a much better way of memorizing these. I don't need you to worry about every single one of these. What I need you to do is right here, the 8 eyes. 8 eyes, much easier. And this is why when somebody comes to DK, you need to be thinking, what is the cause of the DKA? Not just they were table friendly over the holidays. Had plenty of that. Plenty of that. Had a lady come in, her husband was a surgeon. Sugars were out of control. Yeah, it was around Christmas time. And she said, yeah, I've just been spending time with family, eating what I want. drinking what I want. I said, okay. I looked at her husband, he said, I went to workout. Okay, sir. I said, what, I guess you probably wanted troponin too. Because why? Right there, infarction. That's what he wanted. He said, you're damn right. Everything came back fine. She'd just been lacking discipline when it came to food. Holidays, I get it, but you want to think about these things. So that infection, is there an underlying, is there a sepsis going on? These people infected somewhere? Infarction, we think in mind. Non-compliant with therapy. For infant, is this lady pregnant? We need to get an HCG, because that'll be, ischemic, worried about a stroke. They're doing something illegal, and iatrogenic and idiopathic. Idiopathic because that person hasn't been diagnosed yet. They haven't been diagnosed. I can tell you how many times I catch that, and that's a tough thing to try and bring somebody up to speed in an emergency department with their diabetes. Got to get them consulted right away. Most hospitals have a diabetes class they can go in, but you pretty much have to discharge that person with at least a glucometer, right? A little bit of information. Talked about this. So, combination of hyperglycemia causes volume depletion, acidosis, starts getting bad. This isn't like when somebody's blood sugar is around 400, 500. Usually when they get that blood sugar, it just says too high to count. Too high to count. Just gotta start bringing it down. But again, questions to ask. Polydipsia. Are you thirsty all the time, drinking all the time? Polyuria, are you urinating all the time? I'm like, a lot, like, it's ridiculous. And then we start getting that ketonemia. Usually we see that in the urine. Sometimes we gotta find it in the blood. And then again, you see that increased ventilation, that's called Kussmaul breathing. You want to look that up on the internet. Sorry, no clips, I can't find anything funny that deals with DK. Nothing there. But, and then this prostaglandin release is also what can cause nausea, vomiting, which just increases the volume loss. Well, they're urinating all the time, but now they're vomiting it out. And then abdominal pain. Talked about that. Vomiting increases the potassium loss. Don't want that to happen. What I want you to pay attention to, and I would definitely know this, that's why it's highlighted. So it doesn't matter how high the sugars get. We're in order of osmolality. And osmolality is going to tell you how altered that person can get. So when we talk about hyperosmolar hyperglycemic syndrome, and we're not dealing with DK, sometimes we get that, but osmolality is going to give you an idea of that person's level of consciousness. The higher that osmolality, the more altered they are. Osmolality, definitely, make sure you know that. There's a Kussmaul breathing. A lot of people say, anybody smelled somebody's breath with diabetes? Smell fruity? I've had one patient that I saw, I was like, man, that smells like juicy fruit. Most of the time, usually not a smell with that, usually not. But doesn't mean I need to go in and talk to every patient. I mean, you do it for the whole man. It's weird. And I don't want to smell anybody's breath, but crazy. And then make sure just because they don't have a fever doesn't mean that there's not some underlying infection. People just, I told you, they present very atypically. So they can have hypothermia because of that vasodilation from all the sugar. And then maybe this mixed picture because that prostaglandin, they're having abdominal pain. You're like, oh, this is like a abdominal pain issue. We'll get into that in block 3. So, but that pain can be due to all these different things. You can get dilatation. You get an ileus, which means things aren't moving along. Not having peristalsis for whatever reason, and then pancreatitis can also develop. How do we diagnose that? DK, blood glucose above 250. Now we're going to have an anion gap. You can calculate that, but you know what's pretty sweet is they give that right at the bottom of the lab, so you don't need to calculate it. bicarb is low. Why? Because the body's sucking up all that bicarb because of the acidosis. And then pH, obviously, if pH needs to be below 7.3, that means they're acidotic, hence diabetic ketoacidosis. Definitely need to know that. Ketonuria, meaning it's in the urine. Ketonemia, meaning it's in the blood. So, if you don't find it in the urine, you need to check it in the blood. Check it in the blood. Here's other types of things, keeping on your differential. So, alcoholic ketoacidosis, somebody that goes on a bender. Starvation ketoacidosis, renal failure, lactic acidosis. And then I talked about those ingestions. Those 3 ingestions, that person's going to come in with tachypnea. Not very often that you're going to see some come across ethylene glycol or methanol, but salicylates, absolutely. Because aspirin's pretty easy to get a hold of. What also is salicylate? It's kind of crazy. It's a medication that's used to treat stomach issues. Pepto, salicylate. It's crazy. I mean, people are chugging bottles of that trying to help out their stomach and cause salicylate overdose. Just be aware of that. What do we want to get? Right away, that D-stick. Usually that's done out in triage before you even get them back there. And then we need a VBG. Okay? We used to get ABGs all the time. Now VBG's a lot easier to do. We're not having to look for an artery. That VBG, what's that going to be? What's going to be different between an ABG and a VBG? So usually oxygen saturation, right? Because we're getting venous versus arterial, so it's already gone through the body, and now it's on its way back to the heart to get reoxygenated. That's about the only thing. We can make all our clinical decisions off VBGs now. And that's bedside, you're going to get it right away. So CMP, that's just a basic metabolic panel with liver enzymes. We need to get a CBC because we're trying to rule out all these other different types of things. There's 8 I's. And infection being probably the most concerning. Calculate the NIDAP, you don't have to calculate that. It comes out, at least in the military system. So, and there's potential for ABG. That's usually going to be done if that person goes to ICU. Who's really good at getting ABGs in the hospital? RT. That's their deal. Especially when they got to make clinical decisions because the person's in a coma. Like I need to make decisions on how much PEEP I'm going to give them, tidal volume, all that fun stuff. Let them figure that out. But those people are pretty damn good at getting those. Here's our other testing. So get ketones, whether that's urine. That's the other reason to get a urine. I want to make sure that maybe it's a UTI. It's urinary tract infection that's causing this decay. So, and then very, very important, potassium. We don't start getting crazy with treating this until we have a potassium gap. We need to know where that is. It's extracellular, it pushes it out, third spaces out of the cells. So increases that osmolality, which causes altered mental status. So we need to check those types of things. Very important that we get that EKG. Why? What do we want to rule out? Yeah, an infarction. So ischemia or infarction. If you were to see that as a test question, why we're getting that EKG, we need to rule out any ischemic changes. There's always potential to also look to make sure that that K isn't, potassium's not throwing EKGs off. What is hyperkalemia? What does that look like on EKG? PT waves, like across the board, like the entire EKG. Not just precordials, you're going to see it through V1 to V6, 1, 2, 3, AVL, it's going to be across the board, So, what do we do with these people, treatment-wise? Obviously, look at our ABCs first to make sure that you don't need to act on that. Pretty easy to check that type of thing. For the most part, these people are doing pretty well. Well, we're going to start an IV right away. Fluids, their volume down. And what are the fluids going to do? They're going to start diluting out that glucose, help this patient out. So that's the first thing we do. Then we look at the K, but in the process of that, let's get them going with fluids. Fluids right after that. And then we don't mess with insulin until we have that potassium figured out. If we start pushing insulin, we're gonna drop that potassium even worse. And if it's already less, we need to replete it. Got some slides here for that. There's your initial bolus. So isotonic, starting at 20 mL per kilogram, that's a pretty good sized dose. And why I said it's a big dose, because the majority of these people that are in DKA, probably a little on the heavy side. A little bit on the heavy side. So, and we want to check that potassium. We're not touching insulin until we have that potassium figured out. We want that in the sweet spot there between 3.3 and 5.3. But we are going to add that because once we start that insulin, it's going to drop the potassium. So 20 milliequivalents. So that's just going to be piggybacked in with the fluids. Everybody understands what that means. So fluids are going to be hanging. They're going to have a separate bag with potassium in there, but they're going to be going into the same IV. Okay? But we need to start repleting that. And then once we hit 250, we switch them over to D5, D5W, and let that ride until that gap closes up.
So just wanted to clarify, you're not holding the potassium until, or you're not holding the insulin until you correct the potassium.
Correct. You do not even reach for the insulin until you know what that potassium is. And even then, I mean, you're not, the only time you're not going to get potassium is if you're above 5.3. There's some more slides here that for visual folks, I believe here. So, again, insulin infusion, we make sure that bicarb gets well above where it needs to be. We've done away with the acidosis and we've cleared that in ICAP. Now, majority of you are not gonna have this to that point. It's good to know for ICU. I'm not gonna keep that person. Once I've identified them with DKA and I start treating them, I'm calling upstairs. I do not wanna mess with hanging on to that person that long and figured everything out. Now we'll talk a little bit about some little intricacies with that. As far as, I usually don't start an insulin drip. And I'll explain that here in a minute. But, all right, we don't reach for bicarb unless we have to. Bicarb's like a last-ditch effort. Bicarb for TCA overdose, bicarb for significant acidosis. I don't need you reaching for bicarb. What do we need to be doing? So, we have that suspected at triage. We need aggressive fluid therapy. That should be initiated before you have any of these labs. They're volume down. We have to get going after that. And there's all your goals. So, volume repletion right there. Volume repletion. Like I said, they're 4 to 5 liters down. If you're dealing with an HHS, hyperosmotic hyperglycemic state, those people are typically about 10 liters down. About 10 liters down. And then this whole continuum, we're fluid resuscitating them, but we're also trying to figure out what caused the DKA. What caused it. Yeah. So this person's going to be down in the emergency department. We're going to be checking them every hour. We want to see, make sure that's dropping. I typically hang on to a person once I've identified them, maybe 2 or 3 hours in the emergency department. I'm calling upstairs. I want them out of there. I do not want to be focusing on fixing their gap. I do not want to be focusing on where's their acidosis at. I want to get them admitted, but I want to make sure that I've at least hopefully identified if any of those eyes were happening. Okay? Are they stroking? They having a heart attack? I want to have that at least figured out, like what was the cause of the DKA, and then I'm turfing them upstairs as quickly as I possibly can. Let them deal with all those values. I'm not worrying about that in the emergency department. Unless it's just completely booked up upstairs, which it has been. But that was back in COVID days. People would sit in the emergency department for 24 to 48 hours. But again, emergency department trying to be efficient. But if you are hanging on to them for that long, glucose every hour, and then we need to be looking at those electrolytes every 2 hours. If you're hanging on to them that long. But again, you shouldn't. You should not. Again, isotonic saline, so normal saline, we're not reaching for anything else, lactated ringers, we want normal saline, please. And then likely replacing that potassium during that window. No bicarb, and then low dose insulin therapy. Your hospital may have a protocol for that. At BAMC, I call them up, I go, hey, I got this person DK, I'm just waiting on the potassium to come back in, I'm giving them fluids. I'm trying to figure out what the cause is. And I'll say, what do you want me to do? You want me to start them on an insulin drip? Because that's the book answer. But if you give somebody on an insulin drip, guess where they're going in the hospital? Insulin drip requires them to go to the ICU. Most hospitals, they can handle DKA just fine, they don't need to be in the ICU. So I will talk to the internal medicine folks and say, hey, I got this person DKA, already replacing their potassium, I got them on fluids, and just waiting on a few more labs. Troponin came back fine, EKG looks good, I don't think they're stroking out. Could be an infection, I'll start them on some antibiotics if it needs to be. But then I say, hey, what do you want me to do for their insulin? Most of them are just like, hey, can you just give them 10 units and see how it works? Because then I just didn't buy them an ICU. They like it a little bit better. Or they may say, hey, just give them 15 units and continue the fluids and work it down. We'll be right down and see them and get them admitted. It's the way that can work. So again, make sure that we fix that K. We need potassium. So this is the most concerning type of thing. So more concerning is making sure that that hypokalemia is being repleted. It's more important than getting their glucose down. You put them into a lethal arrhythmia because you let that potassium drop out. You're in a world of hurt. Now you're doing a code. You don't want to get to that point. Visual for you right here. You see the only time that we're not giving potassium is if they're above 5.2. 5.2. Otherwise, we are giving them potassium. Holding the insulin when it's below 3.3. And then we're giving potassium and insulin if they're in that nice sweet spot there. Everybody good on that? Okay, these people are getting admitted, definitely getting admitted. So, I see ICU, obviously, if they're critical. And if they're critical, that means they said, oh, I want you to go ahead and start them on an insulin drip. That person's not doing well, we need to give them an insulin drip. Versus med-surg ward. So, those are usually pretty healthy people. So, there is potential, if it's early, that person doesn't need to be admitted, you get it reversed and they're doing great. They have no acidosis is fixed quickly. But I'm not gonna hang on to somebody for 6 to 12 hours. Not in the emergency department. Yeah, you hang on to somebody that long, that's a bed. Should have had 4 or 5 people. Now in the military, a little bit more common to have people longer in the emergency department. Civilian places, they crank them in and out. And the fight for it there. I'm gonna test you on this slide 20 times, not kidding. So, it's just very visual, folks. I'm not gonna test you on anything like that. Just some check on learning. Anybody have any questions on DKA?
Just to confirm, sir, so when the potassium is below 3.3, you give the potassium, and then you were saying that you call up higher and ask if you should send them off to get insulin, or do you wait for their levels to regulate before you
No,
get insulin?
I'll say, hey, I got this person DKA, I'm about to start them on insulin, what do you want me to do? Because some school of thought they're gonna be like, yeah, go ahead and start the drip. I'm like, okay, I see you, here it comes. Versus I just give them 10 units and then monitor it, and they'll come down and take them upstairs.
So when it says hold insulin, you're just waiting for the potassium to get back into normal.
Or if it's below 3.3, I'm not giving any insulin until that's above. It has to be between 3.3 and 5.2. And then I'm giving potassium and insulin.
Thanks, sir.
Alrighty. actually had people pick E. I'm like, I didn't say anything about, all right, like, no. It's obviously C, right? And it may not say that specifically, but we're also ruling out ischemic changes. Synonymous, MI, ischemic changes, infarction. Good? I specifically said no bicarb. Bicarb is a last ditch effort. If you're slamming somebody with bicarb, they're probably coding on you. Sodium is not a big concern of that. C, right? That's our first priority. Not giving the potassium. We need the fluid. There, volume down. That's going to start diluting the hyperglycemia right off the bat and start dropping it. Now, typically, people will drop about 100 glucose in an hour. It's about average, give or take. Yes?
Is there someone like that patient who's sitting on that lower limit of normal for potassium? Would you still go ahead and give him fluids and then give him potassium and then give him insulin just because they're right there?
Yeah, I mean, this particular case, I'm gonna get the fluids first, and then I'm gonna say, hey, let's go ahead and get 20 milliequivalents of potassium. But the fluids are right there in the room.
Right.
Potassium's gonna have to come up from either a Pyxis or it's gonna have to be tubed up from pharmacy downstairs or wherever your pharmacy's at. We wanna get the fluids going first. Keep in mind, I mean, if we want any type of medicine, unless it's in a crash cart, potassium's not kept in a crash cart. Everything to run a code is epi, adenosine, all that fun stuff. Ooh, this is kind of a tough one. So let's break it down. Diabetic, okay, means either hyperglycemic. Keto means they have ketosis and then acidosis, low blood pH. It's E. E is your answer. E is your answer. You can throw all those other ones in and maybe, can you have polyuria, polydipsia and not have diabetes? Absolutely. But if you have those three in E, you definitely have diabetic, keto, acidosis, exactly what the word says. We good. Hope so. We'll see.